My name's Katherine Howell. I'm a paediatric neurologist at the Royal Children's Hospital and a clinician researcher at the Murdoch Children's Research Institute in the Neurosciences group. Much of the work I do, particularly the research work, is in severe epilepsies in infants and very young children, and the vast majority of these have a genetic basis. We had the ability to do single gene testing, which could diagnose some disorders, but one of the problems with paediatric epilepsies is that there are many different genes that can cause the one clinical problem, and one gene that can cause lots of different clinical problems. What that means is it's much more efficient to have a technique where you can test multiple genes at once, rather than one gene at a time. Our ability to make diagnoses and make early diagnoses is much better, and from that comes a number of potential benefits. There are unfortunately very few of our conditions that we have specific treatments or cures for, but there are often ways in which we can make an impact, and particularly one of those is choice of seizure medications. There are some where we clearly know that some medications make a condition worse or better, and that can really improve seizure control, often keep children out of hospital, keep them more generally well. There are also implications for families from a reproductive counselling point of view and the kind of decisions that they will make if they want to have more children. A single physician might meet one or two patients in their career with a particular disorder, but if you've got a support group that's got 200 patients, well, that has huge benefits and potential to advance our knowledge over and above the support and camaraderie and benefits that families get from that aspect of things. There's a number of clinical challenges. The first, I guess, is knowing what the place of genetic testing is in the diagnostic investigations of particular disorders. For our practice at least, while genomic testing has made huge differences, we need to recognise that it's one of many diagnostic techniques we have, and there are major benefits and advantages to some of the other techniques, and genomic testing is not able to replace all of those benefits. So the most pertinent example for us, particularly in the infant population, is that there are many disorders of brain structure, and we use MRI scans to find them. Some of these structural disorders, particularly if they only affect a small area of the brain, might actually be amenable to epilepsy surgery, which can actually cure their epilepsy. The other challenge, I think, is in getting education and understanding around the technologies, and that goes both for health professionals and for patients, so you can get appropriate informed consent and they can understand the reasons for doing the testing, what we might or might not be able to find and exclude, and what the results actually might mean, because the results aren't always black and white. In fact, they're frequently not. Even though I'm a neurologist who does quite a lot of work in a genetic field, I'm not actually a geneticist, and I'm not trained as a geneticist, and I think recognising your limitations is a really important thing as well, and this ends up being a real team effort at the clinician level. We're all going to need to be upskilled.